our first topic for the morning is going to be clinical management of prescription opioid use disorders, and I know that Len Palauzi was going to speak a little bit about the background there, and I'm not going to say more than I already said, so as I mentioned, we'll have some extra time, but we have 3 talks coming up. The first is Knox Todd, who's going to be talking about the ACEP clinical policy review and implementation of the clinical guidelines. Then we have Kavita Babu talking about hard conversations, addressing patients with chronic pain, sort of the issue I raised previously. And then finally, Ed Boyer is going to do facilitation through technology, prescription drug monitoring programs. So we will go ahead and get going. And so our first speaker is Knox Todd, who looks like he's ready to go. And Dr. Todd is, I've got to flip to my other.
He's jet lagged.
You're jet lagged. Okay, well, I can compete with you for that since I just got back from France yesterday. But, I will look up the other speakers more quickly, but I'll let you introduce yourself.
Good morning. I think it's a small group. I think we can let go with some of the formalities. My name is Knox Todd. I know about half of you. In fact, I've known half of you for quite a long time, and it's getting longer now. I'm the chair of emergency medicine at MD Anderson Cancer Center. Does anyone find that surprising? We're the first academic department of emergency medicine in a comprehensive cancer center, and I always include in the world, just so my faculty can laugh at me. It's an interesting place to be, and I've had about two years now at MD Anderson, and I've looked a bit more at pain and opioid use issues, and it is a really interesting perspective, just as a background. My views have changed a good deal over the last couple of years. Before we get started, how many of you have ever sat on a guidelines panel, helped to write guidelines? How many of you were really pleased with the process? I mean, let's be honest. Guidelines are frustrating things to do. Politics is really frustrating. The fact that the government is shut down is frustrating to me right now. So let's share our pain and see how we can move through this. I'm very excited that we have this lunchtime session to work on what's next. Emergency physicians tend to be people who act with limited information. There is no opportunity to collect more information on an individual patient when they need an intervention. So those of us who come from more pristine ivory tower settings where we must have the randomized control trial, Ed, often aren't emergency physicians. We have to act in the face of our best guess at the time. And I think the lunchtime session will be a good opportunity to explore more of that. First, let me give you my disclaimers. I do some consulting. I work for, do some consulting actually for CVS Caremark, which has been really interesting to understand how a large pharmaceutical or pharmacy entity is dealing with some of these issues. I have a limited amount of grant support. I'm very excited that we'll be able to report on some non-opioid approaches to pain control among the elderly, probably next year, that I hope you'll pay some attention to. I have worked with ACEP in the past and the Emergency Medicine Foundation on various grants, some of them pharmaceutical co-funded, and I do some clinical trials in our emergency department and I hope that will be growing. One of the things that came out of our guidelines panel process that I'll be talking about today is a concern that our guidelines would simply exist on paper, exist in the ether, and make no sound and have no impact. So one of our follow-up approaches to this was to develop, or attempt to develop, an active CME program to understand how these guidelines influence practice, if they do. what is it about these guidelines that are important? We're going to talk about the guidelines a bit. You'll see in some cases how limited they are. But they, I think, give us some permissions to think about our opioid prescribing in a new way. And the goal of the project we have, we're about 6 months into a 2-year project in Harris County, working with 25 to 30 hospitals to better understand how these guidelines are implemented and disseminated and what real impact they have. And I hope to have some new information for you soon on that. And our goal is to develop a vibrant CME process that any emergency department can use, a quality improvement program that is built with some science behind it that will help move this issue forward. I'd like to recognize all the members of the ACEP opioid guideline writing panel. Some are here in the audience. And I'd like to point out that one of the important things when you put a guideline together is some of those first choices you have to make is who's at the table. I think ACEP should be congratulated for bringing a broad representation of people. I think we could have done a little better with regard to geography. That's always an issue for us, I think. But we have toxicologists, a number of toxicologists. Lewis Nelson and I have worked a good deal in a conversation around opioid prescribing from the perspectives of an emergency physician who's worked a bit in the pain community over the years, and others who spent much more time on in the tox community. Pharmacies represented. We have had nursing representation. We had strong methodologic support for this project, and then our partners and funders for this process from the CDC and the FDA. That was a very important input, and I'm sorry that we don't have them today. Sorry, my voice is going here. We all know the problem. I don't think you would be here if you didn't understand that there was a problem with opioid prescribing in the United States. I think you're also wondering what emergency medicine's role is in this process and how we deal with it, dealing with patients day to day. Many other speakers are going to talk about the problem of pain and opioid prescribing in the emergency department. I'll just mention that we see a lot of pain. 42%, I think, is what we quoted in the guideline. Some of our studies would suggest that pain is the reason for presenting to the emergency department in adults for up to 70–75% of patients. Kind of depends on how you define it. We see a lot of pain. We are the pain docs. You'll also see a number of slides that talk about the really remarkable rise in opioid prescribing in the United States over the last decade and a half, accompanied by a fourfold rise or so in prescribing, a fourfold rise or so in overdoses and deaths, generally speaking, over the last decade. I'm going to try to talk a little later about the history of what we're seeing here and how, when I look at this, I see echoes of the history of the United States in the late 1800s and through the 1900s. It's an interesting parallel that may contain some lessons for us. If you think about it, after the Civil War, we had many veterans with chronic pain issues, saw large increases in opioid use. We saw the industry, the pharmaceutical industry, blossom around this issue. I'll show you some slides later. And we saw the negative consequences of abuse and addiction, particularly among veterans in the late 1800s. If I was going to just broadly characterize the 1900s in the United States, this is when, anyone remember Cope's early diagnosis of the acute abdomen? Okay. So we know in 1922 our surgeons began telling us that one could not give an opioid to a patient with an acute abdomen. And this was a strong, very firm statement through most of the 1900s. Some of our very courageous colleagues did randomized controlled trials to look at the acute administration of opioids to patients with abdominal pain, and gradually convinced and co-published with our surgical colleagues evidence-driven use of opioids in that setting. So practice was really remarkably different in the mid part of the last century with regard to the later part. In the 60s and 70s, broadly speaking again, overly generalizing I know, we learned that cancer pain could be treated, and opioids were the treatment of choice for those patients. We markedly increased the amount of opioid prescribing we did for terminal cancer patients, 60s, 70s, 80s. Some in the pain community generalized those messages from chronic pain to chronic non-cancer pain. This was a tremendous initiative. You all remember the Joint Commission coming in with pain-related standards over the last decade. And how many read the IOM report, the pain treatment report published in 2011? And the great emphasis in that report was on undertreatment of pain, right? That was 2011. That was 2 years ago. So we've seen lots of different influences. We started to see this signal of adverse effects related to increased opioid prescribing in the early part of this century. Recognized that signal in the early 2002, 2004, 2005, and some courageous people started publicizing those issues. And that's the wave of history we're in the midst of right now. So we talked a little bit about the rise in opioid use, and one of the questions I think we asked in our specialty early on was, what is our role? Or how much of the problem are we? This is from Norvokow in a number of publications. NIDA looked at what specialties were contributing to opioid prescribing. And certainly in the young adult age group, age 10 to 30 or so, oh, thank you, age 10 to 30, otherwise I would just keep doing the caffeine and the speech would go faster and faster. Oh, that's very good. Thank you. But we are a large proportion of the prescribing in an age group in which we are, of course, the largest provider of care. Young people aged 20 to 29 or to 30, 35, they're not going to see their primary care physician, particularly males. So we do provide a large part of that medical care. Obviously, we provide a large number of those prescriptions. I think some of us still have questions about what the magnitude of our prescribing is. To what extent do emergency physicians contribute to the public health opioid supply in the country? And that's a difficult answer to get, and clarity on that is one thing I would look for from speakers today. There have been a number of efforts to deal with the problem of opioid adverse effects. We've seen at the national level the FDA mandated REMS process for industry. Industry is now responsible for paying for physicians' education around the potential risk related to opioids. We can think about how that might turn out. I think that always raises a few questions in the room about where the money goes, who utilizes the money, and then how it is, what influence that has. We could talk about that a bit more today. I think the incredible thing for me has been to see the local and state response to a local and state, what was perceived as a local and state problem. Milwaukee in the early days, honestly, I don't recall the physician community hospital who called me up about 5 or 6 years ago and said, I want to start a program in Milwaukee. How do we do it? And at that time, I was getting a number of calls from medical directors who said, we want an opioid-free emergency department. And I said, good luck with that. And then started giving them some scenarios. Who are you not going to prescribe for? Is it the CEO's daughter with a fracture? Is it who is it? So my Milwaukee colleague actually had a very thoughtful plan, went to the medical board, talked to all the other specialties, got the community together around this issue. We've seen incredible work, Washington and ACEP, Utah, have been leaders in this area and I think have driven this question. Individual emergency medicine groups have established policies. Locally, we've seen, I think, the incredible efforts in New York City, the opioid guidelines that came out, and some of the controversies associated with those that Lewis and I have engaged in a conversation, actually published a few papers on, a dialogue back and forth about all the different issues that our attempts to deal with this problem bring up. We'll talk about them later. Privacy, right? Stigmatization. prevention of these adverse effects. This is a terribly complicated issue. And if I had to characterize the specialty's response to some of these, we tend to protect our providers. Anything that smacks of limiting our scope of practice or limiting the options that are available to us, generally specialty societies tend to resist. So I just have you keep that in mind as we look through some of our policy development. So how are the guidelines generated? There's a very standard process that ACEP has used effectively, I think, since for probably the last 10 or 15 years, whereby we define a question, we ask critical questions we attempt to be very clinically pertinent in those. We use the PICO format. Who knows what PICO stands for? P is patient, population. I, intervention. C, comparison. O, what does it spell? PICO, very good. So a very deliberate process. We have in this case, we reviewed evidence using the standard keywords and looking at bibliographies and tried to use evidence from the last decade, 2000 to 2011. We had, in addition to the expert review by the panel, certainly the FDA, CDC were very involved. We had comments and input by an incredible number of different societies and experts, pain, addictionology, occupation medicine, nursing. The ENA actually adopted this or approved this guideline after it was out. Our occupational medicine people, our interventional pain physicians gave some input to this process. You're familiar with the grading scheme we use. This is typical of many different organizations that proceed to guidelines. We grade, we give recommendations with various strengths. Level A recommendations are generally those supported by high-quality designs, randomized controlled trial, really well-designed studies that are pertinent to our patient population. Level B, oftentimes non-randomized trials. Level 3, often case series, consensus, panel consensus is a common fallback measure that you'll see in all of these guidelines. And here are the ACEP disclaimers. This is really a very small print, but I want to note how ACEP tends to couch some of these. This is not meant to be a complete manual. We're looking at very specific questions. We want to provide evidence-based recommendations and, importantly, point out where the evidence doesn't exist. Part of the guideline output or outcome should be to drive the research process, drive our brilliant young researchers and potential funders in areas that we think are important. And number 3, which is a little faded here at the bottom, is I think our specialties bias. We don't, our bias is probably not to overly limit or restrict emergency medicine practice. And if you read through the phrases here in the third disclaimer, that does appear in the written document. We're meant to guide physicians, provide some information, but not restrict our practice. And that you'll see in almost any specialty guideline effort. So as part of this process, we're developing a quality improvement program. We're trying to implement this in Harris County, Houston, Texas area, trying to involve about 30 hospitals and develop CME feedback between our emergency department groups and ACEP with our group at MD Anderson serving as an expert resource to try to have our physicians understand the problem of prescription opioid abuse, be able to explain the risks and benefits of prescribing for various problems. And a particular focus of ours is how emergency physicians do interact with our statewide prescription monitoring programs. How that works. Does it work? How often does it happen? How can we make it better? How do physicians accept that? Lots of questions around the PMP that have come up in our thinking. So moving to the critical questions. You can read these, but this is the P, an adult ED patient with non-cancer pain for whom opioid prescriptions are considered. The implication is here we're considering opioid prescribing at the time of emergency department discharge. What is the utility of the growing state prescription monitoring programs in identifying patients who are at high risk. All of you, I think, are very familiar with the PMPs or PDMPs, and one speaker is going to be talking about that later. You'll notice that this is a level C recommendation. Most of our recommendations are level C recommendations. There's very little evidence to help us understand the impact as yet of the prescription monitoring programs from a rigorous scientific standpoint. The background to a lot of the prescription monitoring programs started with federal act back in 2005, which of course was not funded, to help drive the development of prescription monitoring programs that had been around in some sense for for maybe 50 to 60 years in some sense. But a really functional electronic prescription monitoring program is something it's a public health experiment we're seeing play out right now. This is at the last count. I think this was October 2012, the number of and status of prescription drug monitoring programs in the United States. Most of us, how many of you practice how many of you are registered? How many physicians in the room? First, all the physicians, raise your hands. How many of you are registered for your PMP? Not much, really? Okay. So it's about, what, 70%, I'd guess? Got you. You do the numbers. Sorry? We do have a bias group. I got to agree. As on the guidelines panel, you take your evidence where you can get it. Megan, what was yours? What was your point?
How many people actually use it on a daily basis?
Yeah.
Registering is a real difference from pulling it up on a patient.
Absolutely, absolutely. Certainly we're finding that out as we explore that in more depth in Houston, Texas. Now, trying to use this data, as a researcher, trying to use prescription monitoring program data has its own challenges, and this is where a strong political hand can be useful. Interestingly, prescription monitoring programs come under various authorities. Pharmacy boards, I think, have the largest number, perhaps, are governed by pharmacy boards. My state, I don't think it's terribly surprising that in Texas, law enforcement would have that data. Does that seem right?
Yeah.
Thank you. Yeah. One riot, one ranger. I think that's what it is. But there's an ongoing dialogue between our board of pharmacy, the hospital association, various specialty groups, and law enforcement. And then having this data in a public health agency with perhaps more of a public health bent to intentions. But even if you sense the tension within prescription monitoring programs and look at that map, and you may get a sense of how some of this shifts back and forth. I mean, and you're probably familiar with one of the articles, the Barron article only from 2010, the first article we published in the Annals to address prescription monitoring programs, the Ohio study. Functional system, I'll paraphrase and probably grossly mischaracterize the paper. I was the editor for this paper as it came through the Annals. But I look perhaps at a group of patients in the emergency department who might be at higher risk for opioid misuse. Well, are any of the authors of that paper in the room first? Okay, good. I always get nervous about that. But generally, a group of patients who might be considered at higher risk, ask the physicians what your plans are with regard to opioid prescribing. You're going to prescribe opioids, how much, what are your concerns? And then push the PDMP data on the physicians to determine what the changes in plan are. And in fact, the authors reported, I think it was about a 42% of plans were actually changed. That's great. That's a lot of new information, right? When you drill down on the data a little bit, in 60% of the time, for a group that at least sounded to me to be at pretty high risk, 60% of the time the physician decided to prescribe a little less opioids. 40% of the time the physician decided to prescribe more opioids. So kind of a wash if you're looking at the total amount of drugs going out the door, which from a public health standpoint might be a very useful measure of population risk. Number of issues with the study. 4 physicians accounted for almost 2/3 of of the patients, but it was a start. It was a first start. And we're starting to see more and more studies of what the prescription monitoring programs hold for us. A lot of broader studies looking at time trends in opioid abuse and trying to correlate those with the development of prescription monitoring programs. But I think the jury's out. We're going to find out much more. I wouldn't be surprised if prescription monitoring programs may even increase the amount of opioids we're prescribing in the emergency department. We'll see. I think this will be an interesting experiment that will play out. But by any reasonable standard, it kind of makes sense to us as a panel that we should support this development. Many of you are aware of the shortfalls of existing programs, lack of interstate communication, the difficulty in getting physicians to accept the technology, which is a large problem in our community in Houston. Systems could obviously be made less cumbersome. It's not as tough as signing up for health insurance these days on a federal website, but it has its limitations. And I think we're all perhaps thinking that this is going to a push system at some point. I will click my prescription for an opioid. I will automatically receive a report that I can interpret. In Texas, I have a great deal of difficulty in interpreting the data as it exists now. Some of our colleagues, the Brandeis effort to standardize what prescription monitoring programs look like will be very, very helpful. Moving on to the statement we made in the annals. Until an interstate, frequently updated, multiple drug schedule, easily accessible, widely used prescription monitoring program is implemented, the likelihood of success is limited. That may be an overstatement. As I go back and think about that, we wrote this about 6 months ago. It does seem to have a little bit of pomposity in it, and I think we could probably rewrite those words. But what is the real impact of the PMPs on diversion, abuse, doctor shopping, mortality, and what is the impact on patient stigmatization or pain under treatment? We don't know those answers. And the privacy question is one that's played out. Certainly it plays out in our internet interactions every day, and I'm amazed at the amount of privacy, loss of privacy that the United States population has become very comfortable with over the last 10 years. I certainly have a much different view of privacy than I had 10 years ago. Is that a good thing? Can be. Is it a bad thing? Can be. I want to apologize for some of the garish colors here. Danielle Campbell, who is my program coordinator, did a wonderful job of putting together graphics. We're working with Articulate, which is a way to build a web interface for some of these things. And then I went in and I totally screwed it up. So I changed some of the colors as I tried to insert some slides. So Danielle, I apologize. She is a very gifted graphics artist. Sorry, Danielle. It actually doesn't look that bad, even with my screw-ups. So here we have a very narrow question. The adult patient with acute low back pain, are prescriptions for opioids more effective during the acute phase than other medications? We were having dinner last night talking about the narrow nature of this question, and I believe in audience participation. So let me ask, again, I apologize for asking this of physicians rather than non-physicians, but we think about acute low back pain, and I'm wondering if we understand who the population is. How many of the physicians in the room in their life have had an episode of acute low back pain? It should be 100%, right? Okay, now keep your hands up. Okay, how many went to the emergency department for it? Okay. Okay. Thanks, Ed. You're a very honest man. So when we think about acute low back pain, we're not the patients in the emergency department. Now, I'm not going to ask you to raise your hand. How many of you took opioids for that back pain? Okay. Now, and I'm really not going to ask you to raise your hand here because this is being recorded. How many of you got those opioids through a physician prescription rather than from a family member or friend? How many of you had old opioids in the cabinet that were waiting from the last back pain episode? Yeah. So this is a reality test, I think, for some of these questions we're trying to. Now, when we say acute low back pain, of course, we're talking about 1% to 2% of our patients. A problem that none of us go to the emergency department for, yet it accounts for 1% to 2% of our business. something like, I don't know, 2 to 3 million patient visits here. Interestingly, acute low back pain in the emergency department is about the same number of patients who go to the emergency department for cancer-related problems, as we're starting to understand the epidemiology of emergency department use for those with cancer. So, good number of patients. Our recommendations here, again, very little evidence of high quality that would support our statements, but a largely consensus-driven panel consensus recommendation that, gee, we shouldn't assume that an opioid is the answer to every patient with acute low back pain that comes through the door. As we're building our pathways, opioid is not always in that pathway as a choice. Reserve opioids for more severe pain, more refractory pain. Most of us, if we think about that, well, they're in the emergency department, they've probably gone through a few options before, but that's not always the case. I have had the patient come through acute low back pain. Have you taken anything for it? No. It may be because they're worried about the cause for that. They're really there for a diagnosis, which is certainly important. Thanks. And you'll see the theme in these recommendations, low dose, limited time. And consider risk for misuse, abuse, or diversion. I don't think any of us would disagree with those statements. I think many of us would wonder how useful those statements are to us, how much it will impact our current practice. Some of our colleagues, the American College of Occupational and Environmental Medicine, routine use of opioids is not recommended. And most of the evidence is that it's hard to differentiate opioids for other treatment. There's some evidence of efficacy for acute low back pain in non-emergency department populations. One of the studies, which was pretty remarkable when we reviewed it, I don't recall the author here, I know someone in the audience knows, is the continued wide use of muscle relaxants and multiple agents for patients with low back pain. Muscle relaxants and opioids are a combination that raise a red flag for me, and one of the things that we should perhaps try to work on. As we try to review the evidence here, lots of evidence in different populations, but the general message was not a significant superiority of opioids over other agents for acute low back pain. Obviously, opioids are more potent agents, and the face validity of those statements is something I think emergency physicians grapple with when we see it. But again, in the presence of evidence of danger or harm, one must act. That's what our specialty does. Now, this was the question that I was most puzzled by. This is a question that in the adult ED patients for whom we're thinking about an opioid prescription, acute new onset pain, short-acting Schedule IIs versus short-acting Schedule IIIs on the basis really of analgesic efficacy as we parse this question. This is the only statement that has anything other than a C recommendation. And indeed, there are a couple of studies that compare basically Vicodin with Percocet and say, gee, don't seem to be much difference for acute musculoskeletal pain generally. And emergency physicians should be able to use those, shouldn't assume that a Schedule II agent is more potent than a Schedule III agent. The determination there by the DEA is that higher your Schedule II is one that is more likely to be abused. Again, lots of difficulties around that statement. As we know, Vicodin is likely going to be moving to Schedule II at some point. So this question, I'm not sure what it means for me. For most physicians, it's going to be a choice between Percocet and Vicodin as the major players here. And finally, question 4. This is a really tough one. Acute exacerbation of chronic cancer pain. Do the benefits of prescribing opioids outweigh the potential harms? Again, no level A, no level B. Level C recommendations look similar to the low back pain recommendations. Don't assume opioids are always the answer. Low dose, limited time. Consider risk. Try to have established continuity of care. In these cases, there should be a continuity provider out there that we can partner with in making these decisions. We're going to consider what contracts are. And I just want to think about who these patients are. This is a study we did a few years ago. Random digit dial survey looking at all patients, to be included, you had to have chronic or recurrent pain and be in the emergency department in the last 2 years. So in our mind, when we think about opioid abuse, I think we are thinking about a particular type of patient with acute exacerbations of chronic pain. If you look at this, these are largely females. They're generally older. Almost all are insured. They have a lot of ED visits. There were some of these patients in the surveys that had 12, 20 ED visits over the 2 years we ask about. Most of them have physicians, most of them taking opioids, and eight or so years mean pain syndrome. Not something we're going to change a great deal with one emergency department visit that's been there for 8 years. And again, how many of these patients do we see? Our survey suggests it's probably about 20 million or so patients, 34 million over 2 years, 20 to 30 million or so. And if you look at earlier data that looked at pain in the emergency department, the proportion of that is chronic. It also triangulates into about 20 million folks or so. So, you know, good hefty portion of the population. I want to, of course, in the guideline process, a large part of what we, I think, need to do is understand how guidelines should be living documents, how they should have an impact. Guidelines that have no impact are probably best not written. It takes a lot of time. I certainly spent a lot of hours with my friends talking about these issues, but I probably could have been doing something else. One of the questions that comes to me from these is, do we decrease the opioid supply in the United States through our contribution toward it, or do we risk stratify individual patients? Do we get very specific? That's one of those kinds of questions that I hope we'll have time to talk about today. Tools that we can use, opioid misuse risk tools, are very important, and I'm very interested in how these work and how PDMPs work. ACEP has a number of dissemination strategies that we're going to be detailing in some of our work. We have a lot of web outreach. I asked ACEP for a list of all the ways they've tried to get this out, and they sent me back a 20-line list of where we're trying to get these out to. So I'm very interested in just getting the ideas out. Really quickly, I want to refer back to the history lesson from 100 years ago. This is the 1880s. Cocaine tooth drops, heroin for various minor concerns. This is where we were in the post-Civil War era. Remember when Bear marketed heroin, of course? I was not around then, Ed? No. But 1898, Bear, industry marketing heroin as a safe substitute for morphine, particularly for kids with coughs, and babies use a less of a dose. I mentioned that somewhere lower down here. Cope, we talked about, the mid-1900s, opioids are verboten. And this is one issue that I saw in the mid-40s was discussion of terminal cancer pain, and how the last thing you wanted to do is addict a terminal cancer patient to opioids. Some of you may know that I got my start in this work looking at undertreatment and ethnic disparities, the remarkable rise in opioid use in the emergency department, maybe 25, 30, 40% rise with consistent ethnic disparities trends. So that's one view of it. I want to thank our project staff. I have a PhD epidemiologist who's helping with this work. Danielle is here helping me as well. We have two fellows who are working in this area. The American College of Emergency Physicians, Cynthia Singh, Marilyn Bromley, and Catherine Mensa are helping us out, as is a colleague in pharmacy at the UT School of Pharmacy. And with that, thank you for your attention, and let's move on.